Welcome to our educational session on the management of hereditary risk. And I actually changed the title a little bit to cover what we are actually, do I need to do something here? Is that better? Okay. All right. Good afternoon. Welcome to the educational session on hereditary risk and moderate susceptibility genes and patients who are at moderately increased risk. So this is a large segment of the population, larger than the high penetrance gene mutation carriers. And we have three really excellent speakers who are going to address the evidence basis for management decisions to be made for this group of patients. Dr. Shah is going to talk to us about moderate penetrance genes and new information that has emerged over the last couple of years in terms of their penetrance and management. Dr. Telenus Lindhorst is here from the Netherlands, and she'll be talking to us about the impressive MRI data-based guidelines and that they can support from data developed in the Netherlands on breast surveillance for this population. And then finally, Dr. Kotsopoulos from Toronto will be talking about hormonal exposure and risk in these genetically susceptible populations. So before we start with the speakers, I would just like to touch on a couple of points that are germane, I think, and that we need to think more about going into the next phase of defining risk management for this population. And I've just displayed here the large number of risk factors that we have to consider in our patients who are concerned about breast cancer risk. And genetic susceptibility is actually a relatively small component of this population. There are many other factors that we know about that contribute to risk and that we have to consider, with age being sort of the overarching modifier that needs to be worked into management paradigms. So assessing genetic susceptibility obviously is the starting point, and estimation of risk, and then surveillance and preventive interventions, medication and hormonal exposures, they all play into the optimal management of this population, where we hope to manage their risk, to reduce it to the greatest extent possible, to find their cancers early if they're going to occur, and to advise them about the best strategies to accomplish this. So where we start often is with MRI surveillance once the risk has been determined. And we are living still with these guidelines that were developed by the American Cancer Society by convening an expert panel. And I just want to focus on that lifetime risk recommendation that came out of that expert panel deliberation, which was a lifetime risk of 20 or 25% or greater, as defined by models that assess genetics history. And so that is something that has continued into the present. At the time, the expert panel felt that there was insufficient evidence to recommend for or against MRI screening in these several high-risk groups that are listed here. But things have changed over the last 15 years, and many of these patients are now being considered for additional surveillance with MRI and other methods. And we really don't have good data to guide us in this group. And we resort to risk estimation as a way to communicate about risk with patients and help them navigate the decisions that they need to make. But the thing about lifetime risk, though, is that it really is not validated. So this is an example of a very nice study in over 100,000 women from the Kaiser population derived from their mammography screening program. And you can see that, that the focus is on the short-term risk estimates. And the confidence intervals on the short-term risk estimates are clearly smaller than on the very long-term estimates of 20 years. And when we talk about women who are in their mid-30s, early 40s, we're actually talking about projecting lifetime risk to 40 or 50 years sometimes. And those numbers really blow up very quickly. And that kind of risk estimation over the very long term really has not been validated. So the confidence interval widens over time, particularly in the highest risk groups. And then the observed over-expected gap also with the addition of additional risk factors tends to increase. So then, the other aspect of risk estimation is that there's disparity between models, discordance between models. So if we look at these two well-validated risk models, the Bodacea and the IBIS, you can see that in this cohort of 1,700 women followed over a long time, 10-year risks. When we look at the upper boxes in the red, the high-risk group was concordant between Bodacea and IBIS in 342 of these 1,400 women when it's calculated over the lifetime. But over the 10-year risk, the concordant number actually doubles because that confidence and the accuracy of the short-term risk estimation is greater than the very long-term risk estimation. So that's something that we have to consider, particularly in very young women, as I said earlier. And these are data from an Australian cohort published relatively recently of 15,000 women. And you can see that for the very young women, the discordance is between lifetime and 5-year risks is pretty large. And the lifetime risks are not, the AUC for the lifetime risks is pretty close to the 50% line. My last slide. Oh, this is the last slide. So I wanted to just quote from this paper, review from Nature Reviews Clinical Oncology by Dr. Tang and colleagues, published a few years ago now, where they pointed to the fact that there's no consensus definition on lifetime risk, and they described the various ways in which lifetime risk has been defined by different groups. And their recommendation and conclusion was that the lack of an agreed upon definition of lifetime risk confounds guidelines based on this measurement. So there is a lot of ongoing discussion about sort of converting to shorter-term risk estimation. We have embraced this in our center, and when we talk to our patients, we really try to focus on the shorter-term risk estimates rather than the lifetime risk estimates in advising them about how to manage their risk and helping them make decisions. And I think this is something that we will be hearing more about in the near future because there are efforts underway to revise some of these concepts. So with that, I will end, and I will turn it over to Dr. Payal Shah, who is Assistant Professor of Medicine at the University of Pennsylvania. She went to medical school there. She did her residency there with a short interval at Memorial Sloan Kettering for a medical oncology fellowship. And she is involved at high levels in various guideline groups, including ASCO and NCCN, and is going to talk to us about cancer risks in patients with moderate penetrance gene mutations.
Thank you so much, Dr. Khan. I would like to thank the organizers for the invitation to participate in this educational session and Dr. Khan for moderating. It is my pleasure today to talk with you about cancer risks in patients with moderate penetrance gene mutations. Here are my disclosures, and here is an outline of what I will cover today. I'll begin with an overview of the genetic landscape of inherited breast cancer, introducing some of the moderate risk genes that we'll focus on. I'll then move forward to discuss the quantitative and qualitative risks conferred by pathogenic variants in these genes, the management of risk in unaffected carriers, and then briefly, therapeutic implications for affected carriers. There are multiple germline genetic variants that can increase the risk of breast cancer. Certainly, BRCA1 and BRCA2 are the most well-established of the high-risk breast cancer genes, although there are several others as shown on this slide. There are also moderate-risk breast cancer genes, including ATM, CHEK2, BARD1, RAD51C, and RAD51D. PALB2 was previously characterized as a moderate risk gene, although more recent data describing its risks place it in the high risk category. The moderate risk breast cancer genes increase the risk of breast cancer by about 2 to 5-fold, and these are relatively common variants in the general population. For example, heterozygosity for ATM or CHEK2 is found in about 1% of the Caucasian population. And these genes confer cancer risks that are modified by and interact with other factors such as family history, mammographic density, and genetic background in ways that are still being elucidated. There are additional genes that have been evaluated for an association with breast cancer, but have been deemed to have low or no risk. And then finally, there are single nucleotide polymorphisms, or SNPs, which are genetic variants that are common in the population that individually carry a small risk of breast cancer, but when considered in aggregate, can add up to a substantial cumulative risk for breast cancer, and this is what we term polygenic risk. So how did we discover which genes are implicated in causing breast cancer? In 2021, there were 2 landmark case control studies that were published back-to-back in the New England Journal. The Breast Cancer Association Consortium published the Bridges study on the left, which included over 60,000 women with breast cancer and over 50,000 women without breast cancer. These participants underwent germline genetic sequencing for 34 genes to estimate cancer risks for breast cancer overall as well as by subtype. The carrier study on the right was a population-based case control study that included over 30,000 women with breast cancer and about the same number of women without breast cancer to similarly estimate risks for breast cancer overall and by subtype. So looking first at the Bridges data, the blue vertical lines represent odds ratios of 2 to 5. If you look on the leftmost panel at breast cancer risk overall, ATM and CHEK2 emerge as having moderate risk associations with breast cancer risk overall, and in the middle panel, where we see ER-positive breast cancer associations, these same 2 genes emerge. On the rightmost panel, with the yellow circles, this is where we see ER-negative breast cancer associations, and BARD1, RAD51C, and RAD51D emerge here. The findings from the carrier study were relatively similar or consistent with findings from the Bridges study. In the top panel, we see genes associated with breast cancer risk overall, and in the bottom panel, we see genes associated with breast cancer by subtype. And again, we see some of these same genes emerge, including the presence of BARD1, RAD51C, and RAD51D when we pull out associations with ER-negative breast cancer. And so it was based on those and other data that our current understanding was developed of which genes are associated with breast cancer. Moving on to qualitative and quantitative cancer risks, I'll begin with PALB2, which, as I mentioned before, is actually a high-risk breast cancer gene, kind of the closest thing that we have to BRCA3. In 2020, the PALB2 interest group updated their cancer risk estimates, including breast and ovary cancer age-specific risk estimates. And to do this, they studied 524 families, almost 1,000 individuals from 21 countries. And they found the following lifetime risks. The lifetime risk of female breast cancer was 53%, ovarian cancer 5%, pancreatic cancer 2 to 3%, male breast cancer 1%. And if we look at the age-specific data, you can see that the risk of female breast cancer includes women diagnosed at younger ages, while for ovarian cancer, the risk really seems more substantially elevated after the age of 60. There was no increased risk of prostate cancer or colon cancer seen in this study. The Breast Cancer Association Consortium also evaluated pathological subtypes associated with these genes, and PALB2 appears associated with high-grade hormone receptor-positive breast cancer, as well as with triple-negative breast cancer. We'll next focus on ATM, and the first thing to say about this gene is that it is large, 62 exons compared with 24 and 27 for BRCA1 and BRCA2, respectively. So there are a large number of mutations in this gene, including pathogenic and likely pathogenic variants, as well as variants of uncertain significance. Among pathogenic and likely pathogenic variants, we do see site-specific variability in cancer risks, and all of this contributes to complexities in estimating cancer risks associated with this gene. So these are data from a study by Hall and colleagues that include a female predominant clinically ascertained population in 2 cohorts, about 4,600 individuals with ATM pathogenic variants and over 600,000 individuals who had germline genetic testing with no pathogenic variants found. They saw moderate risks of invasive breast cancer as well as pancreatic cancer. There were also elevated risks of gastric and prostate cancer seen, although these are less well established across studies. There were low to moderate risks seen of DCIS, male breast cancer, and ovarian cancer. And the ovarian cancer risk does seem to be real across studies, although the magnitude is probably quite small, similar to that for an individual who has a first-degree relative with ovarian cancer. Colon cancer and melanoma were also seen, but are not as well established. I mentioned before site-specific variability with ATM, and the clearest example of this is the missense variant C.7271T to G. This is a variant that results in a lifetime risk of breast cancer of about 50 to 60%, so really in the high-risk range. And this is felt to occur through a dominant negative effect, whereby the heterozygous state results in increased cancer risks, but the homozygous state of this mutation results in a milder form of the autosomal recessive condition, ataxia-telangiectasia. And so this is an example of genotype-phenotype correlations that can impact management discussions. ATM is associated with high-grade, hormone receptor-positive, HER2-negative breast cancer. Moving on to CHEK2. CHEK2 is associated with breast cancer, including bilateral breast cancer. Biallelic CHEK2 mutations are associated with an elevated risk as well as a younger age at diagnosis as compared with monoallelic mutations. And there has been investigation looking into an association between CHEK2 pathogenic variants and breast cancer prognosis, although the data appear conflicting. There may be additional non-breast cancer risks associated with CHEK2, including kidney cancer and thyroid cancer, although the absolute risks are likely quite low. And colon cancer risk is interesting. This has been seen across several reports, although it was not seen in this particular report. CHEK2 also has some site-specific variability. There are lower risk missense pathogenic variants in this gene, including the 3 that are listed up here, and these have attenuated breast cancer risks, and their non-breast cancer associations are less clear. CHEK2 is associated with ER-positive breast cancer more so than with ER-negative breast cancer. Interestingly, there's also an association seen with HER2-positive breast cancer, and there does not appear to be an association with triple-negative breast cancer. BARD1 was looked at in the bridges and carriers data and appears clearly associated with ER-negative breast cancer and triple-negative breast cancer. Yang and colleagues evaluated the breast and ovarian cancer risks associated with RAD51C and RAD51D. They studied a group of 125 families with pathogenic RAD51C variants, as well as 60 families with pathogenic variants in RAD51D. They found that with either gene, there was a lifetime risk of breast cancer of about 20%, although there were gene-specific differences in terms of the age of diagnosis. Both of these genes are associated with triple-negative breast cancer, and RAD51D is also associated with hormone receptor-positive breast cancer. In terms of ovarian cancer risks, both of these genes confer about a 10 to 15% risk of ovary cancer that is mostly seen in women over the age of 50. So here's a summary of some of the cancer risks that we see associated with moderate risk genes. Contralateral breast cancer risk is important when we're counseling patients. We have a limited data set on this right now that does seem to indicate that there is an elevated risk of contralateral breast cancer with CHEK2, but we look forward to the presentation tomorrow morning at the general session by Dr. Yadav and colleagues, which will go into this in more depth. Moving on to management of unaffected carriers at risk. This is a framework for cancer risk management, and it is derived largely from the NCCN guidelines. And although this is a framework, there are many nuances that can inform patients' conversations, including, for example, the presence of a high-risk ATM pathogenic variant, low-risk CHEK2 pathogenic variants, the role of family history in modifying some of these cancer risks, and the less well-established cancer associations with these genes. Management of all of these cancer risks is constantly in evolution, and in fact, there is no international consensus on what I show here, on some of what I show here. And so for this reason, when we see these patients in clinic, we do ask them to periodically check in with us or see us again so that we can ensure that they're receiving screening and management recommendations aligned with the most current data. There are two things in particular that I wanted to point out. First, with regards to CHEK2, as I said, several studies do demonstrate an increased risk of colon cancer, and so this has been incorporated into screening guidelines. So as a reminder, individuals who are in the general population at population risk for colon cancer are now advised to begin colon cancer screening at age 45, recently lowered from age 50. For individuals with a CHEK2 pathogenic variant, we recommend that colonoscopy begin at age 40 or 10 years prior to the youngest affected family member with CHEK2-associated colon cancer. The second thing I would like to highlight is that the age at which breast MRI is initiated in individuals with ATM and CHEK2 pathogenic variants has been modified. Prior versions of the NCCN have recommended that breast MRI begin in ATM and CHEK2 carriers at age 40 or younger, depending on family history. However, the most recent NCCN guidelines recommend that breast MRI begin at age 30 to 35. And this is based largely on the CISNET data, which I show here. So CISNET conducted a comparative modeling analysis of various screening approaches in individuals with pathogenic variants in ATM, CHEK2, and PALB2. And this type of approach is actually quite important because, as you can imagine, it would be very difficult to conduct a randomized controlled trial evaluating all of these screening approaches. They evaluated benefits of screening as shown here, including breast cancer mortality reduction, life years gained per 1,000 women, as well as breast cancer deaths averted per 1,000 women, and also looked at some of the risks of screening shown in the bottom table, including total number of screenings, false positive screenings, and benign biopsies. And they found that breast mammography at any age, breast mammography beginning at age 40 reduced breast cancer mortality by about 36 to 38%, and the addition of breast MRI at any age reduced mortality associated with breast cancer by upwards of 50%. They also found that mammogram beginning at age 40 plus breast MRI between ages 30 to 35 provided the best balance of risks and benefits, and it was on this basis that the NCCN guidelines were modified. But I would like to point out that the actual absolute mortality benefit from earlier MRI is quite small. For example, if you look at the breast cancer deaths averted per 1,000 women for individuals with PALB2 mutations, again, PALB2 is associated with triple-negative breast cancer and hormone receptor-positive breast cancer that is high grade, you can see that we save 2 lives per 1,000 women screened when lowering the age of breast MRI from 40 to 30. Moving on now to polygenic risk. Polygenic risk may actually facilitate personalization of breast cancer risk among carriers of moderate risk pathogenic variants. And this was shown nicely in a couple of studies. I highlight here a figure from Gallagher and et al. And in the top panel in blue, this is the Tyrer-Cuzick remaining lifetime risk for breast cancer for individuals with CHEK2 pathogenic variants. And you can see that the distribution of the lifetime risk is in a bell curve. When the presence of a CHEK2 mutation is added to this Tyrer-Cuzick modeling, you can see in red that the bell curve stretches out. That is, we have more precise estimates of the remaining lifetime risk. And when in green, we add polygenic risk scores to Tyrer-Cuzick modeling, as well as the presence of a CHEK2 mutation, we see that bell curve stretch out even more, so even more precise risks of remaining lifetime risk. Similarly, Gao and colleagues conducted polygenic risk testing in patients with moderate and high penetrance gene mutations as shown here. And they found that PRS can reclassify 30% of patients with CHEK2 pathogenic variants and almost 50% of patients with ATM pathogenic variants as having a lifetime breast cancer risk of less than 20%. And that is significant because according to current guidelines, if patients have a breast cancer risk of less than 20%, we typically do not recommend high-risk surveillance strategies. So if you look over here on the left, ATM and CHEK2 carriers who had PRS scores in the 10th percentile had an absolute lifetime risk of breast cancer of about 12 to 15%. But if we look at ATM and CHEK2 carriers who had PRS scores in the 90th percentile, that jumps to upwards of 30%. And similar findings hold true if we evaluate patients who have a family history of breast cancer. And so one question that we've discussed a lot is, what is the best age at which to start breast cancer screening? And a follow-up question to that is, what is the best metric to guide us when we make that decision? So Dr. Tung and colleagues in 2016 presented a counseling framework for individuals with moderate penetrance gene mutations, and they suggested that women with breast cancer predisposition gene mutations should initiate surveillance when their 5-year risk approximates the 5-year risk of individuals in the general population when the general population begins screening. And so many women in the United States begin breast cancer screening at ages 40 to 45, and at that time, their 5-year risk appears to be about 1%. So if we look at the probability density curves by Gao et al., I added this vertical red line, which represents about a 1% 5-year absolute risk of breast cancer at the age of 40. And you can see that many individuals with ATM, CHEK2, and PALB2 mutations are to the left of this line, as in their 5-year absolute risk of breast cancer at age 40 is less than 1%. So who are these lower risk individuals with moderate penetrance gene mutations? Well, in the same paper, Gao and colleagues evaluated 5-year absolute risk of breast cancer at age 40 by percentile of PRS. And again, I added a red horizontal line where about 1% is, and you can see that there are some individuals below this line, and they tend to have a lower percentile of polygenic risk scores. And so PRS may help identify patients who have moderate risk pathogenic variants, but who are actually at a lower risk of developing breast cancer. And so how might PRS in the future impact management of cancer risk in carriers of these moderate risk pathogenic variants? Well, one possibility is that PRS may provide a more precise estimate of lifetime risk, allowing for reclassification of some individuals as actually having low or population risk. A second possibility is that PRS may allow for more precise age-specific estimates of cancer risk, thereby impacting the age at which high-risk screening begins. But of course, none of this is ready for prime time. We need additional studies, particularly including women of diverse ancestry, before PRS is incorporated into practice in this way. Moving on to therapeutic implications for affected individuals. First, with respect to early-stage breast cancer, should patients have mastectomy or breast conservation therapy, either are acceptable. There has not been shown to be a mortality benefit with mastectomy, and so this often comes down to shared decision-making that takes into account a patient's overall health status and the willingness to tolerate risk. If a patient has a contralateral risk-reducing mastectomy, is a nipple-sparing mastectomy acceptable? The answer again is yes. There has not been any evidence of adverse breast cancer outcomes or increased complication rates with nipple-sparing approaches. And then finally, are there any situations in which individuals who have these moderate risk gene mutations should avoid radiation? And we have data now to, with relative confidence, say no. We are comfortable administering radiation to treat breast cancers, and we typically say treat the breast cancer that a patient has. And that includes patients who have heterozygous ATM mutations. Moving on now to metastatic breast cancer. These are data from TBCRC 048, or olaparib expanded, led nationally by Dr. Nadine Tung. And in this study, patients who had DNA repair gene alterations other than germline BRCA1 and 2 were treated with PARP inhibitor monotherapy. There were no objective responses in patients who had CHEK2 or ATM pathogenic variants. However, among patients with germline PALB2 mutations, there was an overall response rate of 82%. So there are currently no robust data to support the use of PARP inhibition in patients who have breast cancer associated with moderate penetrance breast cancer genes such as ATM or CHEK2. And for patients with germline PALB2, we are still enrolling patients onto this study in the expansion cohort, so it's preferred that these patients be treated in the context of a clinical trial. In conclusion, recent studies have elucidated the roles of moderate-risk breast cancer genes and SNPs resulting in polygenic risk. The moderate-risk breast cancer genes include ATM, CHEK2, BARD1, RAD51C, and RAD51D. PALB2 confers cancer risks that approach those of BRCA2, and this may be reflective of the closely associated functions of these two genes in the DNA damage response. Management guidelines are actively in evolution, particularly involving decisions such as what age do we initiate screening and how do we best incorporate other risk factors such as family history and polygenic risk. Currently, treatment of individuals who have breast cancer associated with moderate risk gene mutations is relatively similar to patients who have sporadic breast cancers. And forthcoming data on contralateral breast cancer risk will likely inform discussions with patients. Thank you so much, and I'm particularly grateful to patients who've participated in all of these studies.
Thank you, Dr. So we have time for questions now. So you can come up to the microphone. And so yes, please go ahead.
Well, thank you for your presentation. Very informative. I have a question about MRI of the breast. The recent update of NCCN guideline with considerations for breast MRI, but no strong recommendation for it. Last year, a study came out of India with more than 20,000 women having education on self-examination and monthly self-checking that showed that it may be very helpful in low-resource countries. And we know that MRIs are pricey and also have high incidence of false positive results. So it's surprising that NCCN does not talk about self-breast exam, and I was just wondering, what are your thoughts on that? Thank you.
Thank you so much for that question. And I think that particularly in lower resource countries and populations, any sort of less expensive measures that might mitigate some of this cancer risk are incredibly important. I also think you bring up a really valuable point about MRI, and in fact, just before this session, we were discussing when, if and when we might actually be able to de-escalate some of these cancer risk management measures. You are correct. I don't think NCCN advocates for self-breast exams, and I think probably that's because in the United States there is relative access to mammography and breast MRI, which have been, mammogram at least has been associated with a decrease in breast cancer mortality, and in the CISNET data, MRI seems to add to that quite significantly. But I think that is an important step to take for women who are unable to access other modalities.
Thank you for that response. I would agree that in a setting where screening and surveillance with imaging techniques is available and there is greater awareness, the value of self-exam may not be as great, but in low-resource environments where those imaging techniques are not available, education and self-exams can certainly play a role. Question in the middle here. Oh, sorry, I'll take that microphone first, sorry.
Hi, Vogel, New York. So, listening to the use of this 20% risk cutoff, at 19, don't do an MRI, and at 20.5, do it. It obviously makes no sense. And the only reason to deal with this cutoff is that the insurance company, you may have a hysterical patient who thinks she will die for sure next month if she doesn't have an MRI. In that case, send a polygenes and the risk score. And if it's high, you can try and convince the insurance company to pay for it. On the other hand, if you have a patient who says, I hate MRIs, I desperately hate MRI biopsies, leave me alone, don't do the polygene risk score, leave her alone. This isn't a matter of life or death. Do you agree? I mean, this 20% number, it's round, but beyond that, there isn't a huge amount to justify it.
Yes, I completely agree with you. I think that the 20% does to some degree feel a little bit arbitrary, but a cutoff did have to be set somewhere. The other thing that you bring up is absolutely accurate, that there are different risk models and different ways to get to percentages that are lower than and greater than 20%. And so I think when we're seeing patients, this is where the shared decision-making really comes into play. We see patients who are like, I absolutely want a breast MRI, and I'm like, okay, then we'll look at that Tyrer-Cuzick score that will get us, above 20%. And there are other patients who say, no, thank you. And we say, that's okay. This is a recommendation, and not all the models get you above 20%.
I've been known to call UPenn and ask for a model that would get my patient the MRI, and I got it.
Yep, yes.
So, Dr. Shah, do you feel that there is a PRS model available today that is reasonable to use in this way to make recommendations for patients?
Thank you for asking that. Currently, I don't. I think that the use of PRS is still investigational, and the best application of it is still something that is being elucidated. So currently, I wouldn't recommend necessarily using that in isolation, I should say, to inform management discussions. If, for example, a patient does have a PRS score, as for some time some of the genetic testing companies were reporting out PRS scores, I would consider that in the context of the patient's other risk factors, but not in isolation.
Thank you. Yes, question?
Siddhi, medical oncologist at Mayo Clinic. I have a question regarding some of the other cancer associations that you presented, colon cancer, thyroid cancer. I guess, could you comment on the studies that looked at this? Because there is significant concern that there is ascertainment biases in these studies, right? Because these are primarily women qualifying for genetic testing. How much can we use this data to make clinical decisions today? And for example, PALB2 and ovarian, ATM and ovarian. I mean, are these truly real, or are these just product of ascertainment biases?
Thank you for asking that question. So I will say first that some of the less clear associations I kind of categorize differently. So I think when we talk about CHEK2 associated risks, including thyroid cancer, kidney cancer, those are probably less well established, whereas I think the ATM and PALB2 associations with ovarian cancer have been fleshed out a little bit better in the data and do seem real. I think the other consideration when we look at these cancer risks is not just which cancer risks seem to pan out in multiple studies and which don't, but what is the absolute risk? So I think for CHEK2, for example, although the relative risk and the odds ratios in some of the studies for kidney cancer and thyroid cancer might be elevated, that still kind of amounts to a relatively low absolute risk. And then that also translates to a very low mortality because some of these cancers are very treatable. So I think the NCCN, for example, has incorporated some language regarding ovarian cancer risks and PALB2 and ATM, whereas I think some of the other less established cancer risks are kind of put in a different category.
Thank you. So I will make a plug here for using absolute risk in communicating with patients, because relative risk can be quite misleading, particularly for rare cancers. So I think you made that point as well. So we'll take one question and then one from the online audience. So please go ahead.
Dan Morgenstern, Hartford, Connecticut. I recognize that the CISNET investigators are very smart. Their paper is difficult to understand for a non-biostatistician, but it is a little bit haunting the way a single paper changed the recommendations for so many different germline pathogenic variants in terms of thresholding. I may have missed it in your comments, but is there an explicit benchmark in terms of both the specificity issues, false negatives, and particular quality-adjusted life years that triggered this change? Because you always have a linearity that if you decrease the age that you start screening, you're always going to find more cancers. Radiologists always tell us that. But what was the particular reason and the particular benchmark that was used to sort of widely endorse this earlier threshold?
That's an excellent question, and I think that your sentiment is kind of echoed by many. To my understanding and recollection, there was not a specific sensitivity or specificity benchmark. It was more an overall assessment of risk benefits that triggered that change. But I would refer back to the paper to confirm that recollection of mine.
Right. There was a fair amount of soul searching, I think, within the group as to whether this modeling approach was sufficient to make a change in recommendations. And I think eventually the majority opinion came down. But your question was echoed by others in that setting.
Thank you.
So we'll take one final question from the online audience, which is the use of preventive medication for these moderate risk gene carriers. And I'll actually take that another step further, is do you think that the data on the hormone receptor proclivity of the cancers that appear with the specific mutations is robust enough to make recommendations for or against endocrine therapy based on the specific gene that's affected?
So thank you for that question. So currently, there aren't any data specific to individuals with moderate risk genes in terms of pharmacologic risk reduction. However, one could theorize that, particularly for cancers that genes that predispose to ER-positive breast cancer, the role of pharmacologic therapy risk reduction may be more valuable. We don't really know, but we also do discuss pharmacologic risk reduction for non-genetic risk, and so one can kind of imagine that there might be a role for it there. So I think this is an area where there is not firm data guiding us, and another area that comes down to shared decision-making and takes into consideration a patient's overall health and side effects of medication.
Thanks very much, Dr.
Thank
Shah,
you.
for your excellent presentation and discussion. So our next presenter is Dr. Madeleine Telenis-Lindhorst. She's here from the Netherlands, from the Erasmus Medical University. And she is actually in the Department of Surgery, I was surprised to find out, and has done an enormous amount of work in terms of defining data for the performance and the utility of supplemental screening, particularly with MRI in high-risk populations, and has been the instigator of several very high-quality studies. So she has a treasure trove of data, and she's going to inform us now about the performance of MRI surveillance in high-risk women, as well as those at moderate risk.
Thank you very much for this opportunity to discuss with you the possibility of MRI mammography screening for women with moderate and high risk. I have no conflict of interest, but I would like very much to thank all the women who participated in all the studies that I will cite, because they give us the opportunity to improve. How effective actually is MRI screening with mammography for women with high risk? There haven't been performed randomized controlled trials, and there will not be, between screening these women with MRI and mammography and no screening. However, there are several observational studies with long follow-up that compared, for instance, in this large study, women with BRCA1 mutations, healthy women, who were screened versus those with risk-reducing mastectomy, and the same for the BRCA2 mutation carriers. Mean age was between 34 and 42. And of course, with screening, you get more cancers than after the mastectomy. Breast cancer mortality was not significantly different when we expected at 65 years for the BRCA2 mutation carriers, 2% difference, but not significantly different. There was a slightly larger difference expected for the BRCA1 mutation carriers at age 65, and that was significant. But these numbers show that also the screening with MRI and mammography clearly reduced breast cancer mortality significantly. And the same was shown by this study from Ellen Warner from Canada. In 500 BRCA1/2 mutation carriers with 20% year follow-up, she expected a 98% survival, breast cancer specific. So that is quite a very good result. Also for women with familial risk, it was shown in this study, which also looked at BRCA1 and BRCA2, but a large part of women with familial risk, that when they were screened with MRI mammography, the survival was significantly better than when they had no screening, and these women were just coming at the outpatient clinic without screening it after they appeared to have familial risk, and they were matched for age and risk group. And recently, it has been shown that in BRCA1/2 mutation carriers, all detected node negative, those BRCA1 and BRCA2 who not got chemotherapy, who were detected smaller than 1 centimeter, had clearly a better 10-year overall survival than those who were detected between 1 and 2 centimeters, although all node negative. And we know, of course, that with increasing size, you also get more node positivity, which also will reduce the survival. So together, that means that detection on average between 1 centimeter is at the moment nearly only possible with MRI. However, should we screen yearly imaging from age 25 to age 75 for the higher risk, and women with different risk profiles all in the same way all those years? To help us guide that, we could look at a growth rate study, which was performed in 50 BRCA1/2 PV carriers and 50 women with moderate risk. And when you look at the size of detection at MRI, for instance, or mammography, and you look back and you know exactly where the tumor is, you can often find a spot and measure the size, and so calculate the growth rate, while at that previous image it was not yet recognizable as a cancer. And when we look at these growth rates, then we can see higher up is a lower growth rate. Blue and red are the BRCA carriers. And on average, in a 15-year older age group, the tumor growth rate in the BRCA1/2 mutation carriers and the women with familial risk, the blue line, got in a 50-year older age group twice slower. However, at the same age, the cancers in the BRCA1 and 2 mutation carriers grew on average twice faster than at the same age in women with familial risk. And the familial risk was actually comparable with women with average risks from previous studies. If you want to have an optimal screening interval, you would like to detect a cancer that you have missed at 2 millimeters at, for instance, 5. That's quite reasonable. And in that same time interval, a cancer that was missed at 4 millimeters would have grown to 10. According to this growth rate study, one should then screen BRCA2 and 1 PV carriers below age 45 once every 6 to 8 months, between 45 and 65 years yearly, above 65 maybe less frequent than yearly, if this MRI we'll see later on. For women with moderate risk, where there's lower growth rates, below age 50, yearly imaging is quite advised. But between 50 and 65, maybe you can screen once every 2 years. And above 65, even less frequent than that. This has been shown in practice in the study for Guandalini, who screened all women with higher than 22% moderate risk BRCA1, BRCA2 and BRCA1 mutation carriers. Sensitivity of MRI was all the time better than with mammography. And in average, all the women got twice a year MRI and once a year mammography, and the average size was 6 millimeters. All the cancers were node negative, and half of the evasive cancers were detected on the second MRI of that year. Mammography hardly added sensitivity, especially if you look at the BRCA2 and not at all in the familial risk. However, especially in the BRCA1 mutation carriers, The MRI recall rate per detected cancer was 3 and the biopsy rate 2, which is quite reasonable. So maybe this is really cost-effective in the younger BRCA1 mutation carriers, but I don't know a cost-effectiveness study for the BRCAs, let alone the women at familial risk for this scheme. However, at the other spectrum of age, should we continue with yearly MRI for BRCA carriers above age 50 yearly? A large meta-analysis has been performed, international, Dutch, Canadian, UK, Italy and Austria. Women were divided between below 50 years and above. Sensitivity of mammography did not improve above 50 years. So MRI is for the BRCA1/2 mutation carriers indeed still needed above 50 years, equally as below that. And above 60 years, do they still need yearly MRI BRCA1/2 mutation carriers? This actually was an older study performed in BRCA1 and BRCA2 mutation carriers retrospectively. At that time, in the guideline in the Netherlands, it was a Dutch study, was that after 60 years, the BRCA mutation carriers got screening either yearly mammography or every other year. And we look at the results. With yearly mammography, we had 20% interval cancers and 20% late-stage cancer. Late stage was defined as larger than 2 centimeters or node positive, let alone metastatic. And with one every other year mammography, that even doubled those poor results, 40% interval cancers and 50% late stage. So we definitely have to continue with MRI screening for BRCA carriers also above age 50. However, we do not exactly know the optimal frequency for MRI at that age. So maybe for BRCA1/2 PV carriers, it may be beneficial to screen more frequently than yearly below age 40 with MRI, especially the BRCA1. We should continue screening with MRI also above age 60 years, as is in the guidelines, of course, also in the Netherlands now. And maybe less frequently than yearly is possible above 65 years, but there are no studies known to me with that scheme yet. The women with moderate BC risk need annual MRI and mammography from age 35 or 40 up till 75 years, all the age range the same scheme. To answer this, the family risk study, a randomized trial, has been performed. All women with moderate risk, about 20%, the arbitrary cutoff point. No BRCA1/2 mutations in this randomized trial and no previous invasive cancers. Half the women got mammography yearly, the other half got yearly MRI and mammography every other year. Mean age was 45 years. There were clearly more cancers detected with the MRI group than in the mammography group. 3 times more invasive cancers with MRI. However, after the first prevalent round in the incident rounds, the detection decreased and was not significantly different anymore. There was a large stage shift. In the MRI, median size was 9 mm versus 17 with mammography significant. Lower node positivity, 60% nearly was smaller than 1 centimeter. We have seen the importance of that. And there were fewer large cancers. Detected in the MRI group only by mammography was 12.5% of the cancers. However, false positive rate was, as we know, larger with MRI than with mammography. But a quarter of the false positive results were caused by mammography. When you look at screening, the results in the long run will more be equivalent to the incident rounds. In the first round, the prevalent round, you will detect all the cancers that are in that population, also large ones if they are there. However, after the first sieving out your large cancers, you want to detect with the more sensitive tool mainly small cancers. And that was exactly what was shown in the on average 4 incident rounds in this study. 50% of the cancers with MRI were smaller than 1 centimeter, only one. With mammography, large cancers, lower number and far lower percentage. Note positive was significantly different, only 2 out of 18 versus 5 out of 8. No interval cancers in the incident rounds with MRI. Specificity remained significantly lower with MRI than with mammography. However, nearly 88% is maybe quite acceptable for this age group. If we would screen 1,000 women according to these incident rules, we could expect after 1 year to detect with MRI 10 cancers versus 6 with mammography, have twice as many biopsies in the MRI group than in the mammography group. However, the positive predictive value of MRI would not be significantly different because of the higher cancer incidence. We looked at density, of course, in this study, and density was well divided over the low density A up till high density between the MRI and the mammography groups. And all the large cancers were both in the MRI and in the mammography group, only detected at the higher density C and D. The cancers that were detected only by MRI were mainly seen at the lower densities A to C. So contrary to what is often said, MRI is most effective at lower densities A to C, although it has been proven effective in the dense randomized trial, for instance, at density D also to reduce interval cancers. And specificity declined both for MRI and mammography significantly with the increasing density. We wouldn't expect to detect so many extra cancers with stoma as been shown by these studies or with ultrasound as with MRI. For contrast-enhanced mammography, there are some data appearing, but no randomized trial yet. And it seems that maybe sensitivity is slightly lower than with MRI and specificity possibly is slightly higher, but we have to await more results before we can have really an opinion about it, I think. There will be some overdetection, of course, in the feminist trial, but the average life expectancy at the moment of the cancer detection was 34 more years, and even ER-positive cancers can metastasize in such a long age span, although fewer with earlier detection. There were an equal number and therefore lower percentage of DCIH, which form a large part of the overdetection with MRI than in the mammography group. To know whether a strategy is cost effective, we have to use modeling. And in Europe, we use an incremental cost effectiveness ratio threshold of $25,000 per life year gained to make it acceptable. And with modeling, they came to the conclusion the screening only with MRI for women with moderate risk yearly from age 35 or 60 years would reduce mortality 30% more than screening with mammography. And we say 35 or 60 years. It actually meant that we should screen starting at age 35 or 40 or 5 years younger than the youngest age in the family, although in the American guidelines that is 10 years. And that has been shown in this study in Cancer 2013, that both the risk group and the ages in the family contribute or predict equally to the expected age of onset in a person you offer and discuss screening with. That yearly screening is acceptable for the US guidelines, but not for Europe. It's too high in e-care. For European standards, screening with only MRI every 18 months from age 35 to 60 would reduce mortality 8% more than mammography and 72% more than no screening for an acceptable e-care for European standards. And comparable effective work, for instance, there are several schemes which are in the paper, but screening below age 50 yearly with MRI and above age 50 with MRI every other year. This was confirmed by the large observational Ontario study. Over 6,000 women with moderate risk were screened with MRI and mammography, 120 breast cancers detected. And below age 40, the addition of mammography to MRI did not significantly improve the sensitivity, but it clearly decreased the specificity. And the same was seen above age 50. There was a 2% increase of sensitivity, not significant, but a clear decrease of specificity to 80%, not optimal. Only in the 40 to 50 year age group, there was a significant, nearly 10% improvement in sensitivity. However, with a decrease in specificity to a rather low 76%. In conclusion, MRI detects significantly more cancers at a relatively earlier age than mammography, however, with false positive results more prominent in the MRI. MRI actually performs best at density A to C, higher detection and better specificity also, and above age 50 years. And screening with only MRI for women with moderate risk can be cost-effective. But for Europe, we should perform it at a somewhat lower frequency than yearly. So if you might be able to offer MRI screening without mammography for women with moderate risk, then do women with a BRCA mutation always need mammography in addition to MRI screening? In this retrospective study, there was regarded that 93 breast cancers detected with MRI and mammography screening in BRCA1 mutation carriers, and mammography added only 2% to DCIS to the detection, all above 50 years. Furthermore, in another study, Obdain et al. Calculated that below age 40 years, there would be more radiation-induced breast cancer mortality than prevented by mammography. And for BRCA2 mutation carriers, the 85 cancers were detected in 5 centers. MRI only detected 1 DCIS below age 40 and nothing between 40 and 50. However, above age 50, 7 additional breast cancers were detected by mammography, and it increased the sensitivity 16%, and that is quite considerable. And again, the same was demonstrated in the large Ontario study, with nearly 2,000 BRCA mutation carriers screened with MRI mammography and 115 cancers detected. Below age 40, there was no significant increase in sensitivity, and of course a decrease in specificity. And again, the same was seen in the age 40 to 50 group. There was a 3% increase, but that did not reach significance, and there was a clear decrease in specificity. However, above age 50, there was a significant increase of nearly 10%, and a decrease in specificity to actually, for this age group, acceptable 88%. So in conclusion, and this is not the guideline, this is my personal considerations, we might screen carriers, BRCA1/2 PV carriers below age 40 with only MRI, as is advised in the guidelines, but possibly more frequently than yearly, especially for the BRCA1 mutation carriers. For the others, no cost-effectiveness studies. Between 40 and 50, as far as the evidence has gone, maybe only MRI yearly. Above 50, we have shown a clear increase of sensitivity with additional mammography, so we should add mammography, but should we do so yearly or biannual? And above 65 years, when also in the BRCA mutation carriers growth rate on average slows down a bit, should we continue with yearly MRI, or might we maybe alternate MRI one year and mammography the other, but there are no studies yet with those results. Because do we know whether radiation-induced breast cancers decline with age in BRCA1 and 2 PV carriers who have a hampered repair mechanism for DNA damage, which may be caused by the radiation, and that hampered mechanism doesn't improve with age, while the incidence goes on with age. And we can find that very well explained in this recent study from Yoshimura et al. For moderate risk, I might conclude, and that's mainly from the family risk study, the screening yearly with only MRI below up till age 60 is cost-effective in the USA threshold. For Europeans, however, screening with only MRI every 18 months is cost-effective within the threshold. And there are many schemes in the study, in the cost-effectiveness study. One of them is yearly MRI below age 50 and every other year MRI above age 50. In this family study, all the women there after age 60 went to the national screening, which is mammography every other year. But after this study, cost-effectiveness study was published, the then study, cost-effectiveness study was published, and that showed that even with for women with a slightly lower risk in the highest density from the normal population above age 50 years, it is cost-effective to screen with MRI, but then once every 3 or maybe 4 years. So maybe in the women with a higher and moderate risk, it may be better also to continue with MRI screening, but maybe at a still more lower frequency every 3 years. I would like to ask you a question to end with. Do we know whether radiation-induced breast cancer decline with age in the BRCA1 2 PV carriers because of the hampered repair mechanism, as I mentioned? And do we know the balance of radiation-induced breast cancer mortality versus prevented in the moderate risk genes, some of which also have a hampered DNA repair mechanism? And that by age, because that would help very much in deciding on the addition of mammography at different ages. I thank you very much for your attention.
Can you stay for questions? Yeah. Yes, center microphone.
Hi, Dr. Jessica Jones, UT Health Houston. I had a question and also a comment. Thank you, Dr. Linthorst, for that lecture. It was wonderful. My first question is regarding the radiation-induced breast cancer affecting the morbidity and mortality. Do you know if DCIS was included in those clinical trials, not just invasive cancer, and perhaps could that have contributed to the radiation leading to excessive morbidity and mortality, taking into consideration DCIS as a totally separate entity? Well, it can be treated differently. And then my second is a comment to a lot of the populations that we saw in these clinical trials are not necessarily representative of the most pressing women in need of decreased morbidity and mortality. And do you feel there's a call to action to increase MRI screening in our disparate communities to include Black American and Hispanic women? Thank you.
So the first, DCIS was not taken into account. It was invasive breast cancers only. Thank you very much for that great question. I think it's very important, and it's one of the reasons why you might de-escalate your MRI use, because you hope it is then in reach for more people. I don't know exactly, the insurance conditions here in America are different from the slightly more socialistic European countries. And so if we have a guideline, then the insurance will cover it fully. And that is more differentiated here, I think. And I think that is one of the important reasons why we look at de-escalations. But the other very important reason is if you can de-escalate, if a measure is insufficiently contributing to the detection, it does do harm, certainly. And that is not only cost and not only even the induced cancers, but it's also the biopsies, the anxiety, etc. of the screening. So that's why we always have to try to balance it as much as possible. Thank you.
Yeah, so that is actually a really important part in terms of the implementation of surveillance strategies and guidelines, the availability to the whole population. And one aspect that I'd like your opinion on is the advent of abbreviated protocol MRI. So as you know, there was a US trial on this, and I know that it's been popularized in Europe as well. What's your opinion of this, and how do you think that would play into decreasing the burden on both the workforce and the machines and the cost of MRI surveillance?
I hope it would reduce the cost. It certainly will reduce it to some point, but it will not go back to a mammography cost, I think. But then you have to weigh how much is your improvement with it. It certainly will reduce the burden, the workload, etc. It's very promising in the recent papers when they compare the abbreviated MRI with the normal in relation with sensitivity and specificity. So we're really looking forward to those results also in screening. I think it's important. Thank you.
Yes, question?
Stephen Narod, Toronto. Certainly we don't take into consideration the risk of radiation-induced breast cancer. That's a highly theoretical concept and not one that we embrace. When we did a study of our several thousand BRCA carriers, we found no relationship between the radiation dosed by mammography and the subsequent risk of breast cancer. I think it's pretty provocative to suggest that we're inducing breast cancers by mammography. There may be a theoretical basis for it, but I wouldn't say that to my patients.
I think the study from Abdijn was very well calculated. And of course, you have also other evidence, which mainly is from the unfortunate bombing in Japan, etc., and the radiation and the subsequent cancers that occurred thereafter. And then they have brought that back to reduced risks and have tried to extrapolate it. We have to consider that hampers repair mechanism. And we do not know exactly, because it's very difficult if you screen with mammography and afterwards you detect the cancer. How do you know whether it was radiation induced or not? We can't know that. So it's a very difficult thing to study, really. But you have to use all the evidence you have to try to get to the best option and offer the best of screening. But we have to take it into consideration also for those other genes who have a hampered DNA repair, homologous repair mechanism, I think. But
Right,
it's difficult.
so when you asked that question, my response was going to be, how would you study it?
Exactly.
But Dr. Tang is online and has a comment and points out that the radiation-induced breast cancer risk is related to age, since the breast is still developing until age 30. That's the data with radiation-induced breast cancer in the Hodgkin's population. And so that's been the rationale for restricting the use of mammography in BRCA carriers until they get to 30. I think what you have raised with your data is the potential of restricting it even further until maybe 40 in terms of the benefit.
Yes, and of course it's dependent on age and the development of the breast, of the normal breast. But I don't know whether in that development 40 or 30 is really a cutoff point. I can imagine that postmenopausal may be quite a good cutoff point in women with a hampered DNA repair mechanism. But it's speculation. We don't have really exact data, I am afraid.
Yes, center microphone.
Hello, congratulations on the presentation. Sergio Mazzilli from Cancer Institute of São Paulo. What's your opinion about the risk of retentions of gadolinium in the high-risk patients, young patients that do frequently MRI?
Yes, it's a very good question. At the moment, we don't know really the effective retention of gadolinium. To my knowledge, there haven't been published really harmful results from it. But it has to be looked after very carefully, of course. We have to watch it very carefully because we start at a very young age in the BRCA1/2 mutation carriers and they are sensitive. So that is a very good point.
So last question, right microphone.
Mine is really Marie Wood from University of Colorado, and thank you for that excellent talk. And on that same thing, it looks like the concern about gadolinium, I would wonder if you can look at any of those very large studies being done in Europe to really try and tease out the effect of gadolinium deposition.
Can you look at the European data to tease out the effect of gadolinium retention with serial MRI?
I don't exactly know whether it has any harmful effect at the moment, but we have to wait a longer time before we can really know, I think. Unfortunately, the abbreviated MRI doesn't help us in this respect. It would be marvelous if there is a lot of investigation also in MRI without gadolinium, or you would prefer to have another measure instead of gadolinium to use. But it's not on the market yet as effective. And the abbreviated MRI, which is very promising, does use the same gadolinium.
Thank you.
Thank you very much, Dr. Lindfors. So now on to Dr. Joanne Kotsopoulos, who's traveled here from Toronto and is a researcher in the Women's Hospital Program, the Women's, I have to get the right name for Familial Breast Cancer Research Unit at Women's College Research Institute. So Dr. Kotsopoulos has received her PhD from the University of Toronto, and she's been working there for some time now. She was at Channing Division of Medicine at Brigham and Women's for a while as well. And she has a major interest in BRCA-associated breast cancer and has been working on identifying viable strategies for helping these women manage their risk, and has also done a really nice body of work in terms of defining the effects of hormone use and hormone deprivation in this population of women. So we will hear from her on this topic now. Thank you for coming.
So thank you for inviting me here and for the wonderful introduction. Hopefully you're still awake for this last presentation. So like Dr. Khan just mentioned, I'm going to try to do my best to review the literature and where we are with the impact of hormonal exposures on cancer risk in women with a BRCA1 or 2 mutation. A lot of the speakers spoke about the moderate penetrant genes. Unfortunately, I think we don't have any data right now, so I'm going to just be focusing on the BRCA mutation carriers. So to briefly overview my presentation, I'll start with a real quick snapshot of the clinical management of these women, which has already been talked about a lot already by the two speakers. And then I'll introduce the evidence to date surrounding the role of specific hormonal exposures, and in particular the role of tamoxifen use, oral contraceptives, and hormone replacement therapy, and the risk of breast and sometimes ovarian cancer in these women. I will also introduce some emerging data from our team looking at the impact of oophorectomy, so preventive removal of the fallopian tubes and ovaries on all-cause mortality, and then just summarize the evidence and some next steps for future direction. So I think most of the audience knows the management of hereditary breast cancer, specifically BRCA mutation carriers, and here is a snapshot of the NCCN guidelines. We've heard a lot just now about the importance of enhanced imaging with MRI and mammography. But we also know that there's an important role of risk-reducing or bilateral mastectomy in preventing disease, and this is really the most effective way to prevent breast cancer in this high-risk population. So women also have the option, so women with a mutation also have an option to use risk-reducing agents, in particular tamoxifen. And this is something that can be discussed with the patient, and I'm going to return to this topic in the next few slides. So although this is the breast cancer symposium, I don't think we can talk about women with the BRCA mutation and ignore their very high risks of developing ovarian cancer. And the clinical management for this disease is a little bit different because we know that to date, screening has not proven to be very effective at early identification of tumors or for improving all-cause mortality. And so these women are strongly advised to remove their fallopian tubes and ovaries at a very young age, between 35 and 40 for women with the BRCA1 mutation and 40 to 45 with the BRCA2 mutation. We've heard a lot in the literature about the role of the fallopian tubes as the site of origin of a subset of serous cancers, and there is a lot of interest in fallopian tube removal to prevent a subset of ovarian cancers, but this is currently not standard of care in women with a mutation. So those are the guidelines, but what are these women actually doing to manage these really elevated risks? And before I present some data from our team as well as others, I wanted to introduce the study population that I work with. So at Women's College Hospital, I work closely with Dr. Seema Narod and Kelly Metcalf, who are here today, and we are fortunate to work on a large cohort study initiated in 1995 by Dr. Narod, which we call the Risk Factor Analysis of Hereditary Breast and Ovarian Cancer Study. And this has really become a really important resource for us. It's a large international study of high-risk women, and we collect very detailed information from these women at the time of enrollment and every 2 years. And this has become a very important international collaboration, and most of our data stems from this cohort. And to date, we have over 18,000 women that have enrolled from across the globe. So Dr. Kelly Metcalf from our team has used this data and has been able to look at patterns of screening and prevention in this high-risk population. And this is from a recent publication from our team. And when we look at the right side here, we can see that rates of MRI imaging and mammography are quite high. So a lot of women are opting for enhanced screening for their breast cancer risks. Oophorectomy is increasing, so most women are having their ovaries removed at the recommended time. Mastectomy is still fairly low. About 30% of the population that we follow has opted for a preventative mastectomy. But what has been low and remains low is the use of chemoprevention. Here we see that chemoprevention rates are, or we see less than 5% of our population to have used this drug. But what is the true association between tamoxifen and risk of disease in mutation carriers? Unfortunately, most of the recommendations are based on studies, large trials conducted among women in the general population and predominantly postmenopausal women. And there have been no large prospective studies or trials of tamoxifen use specifically in women with the BRCA1 or 2 mutation. And as I just showed you, use of chemoprevention still is low, and this could be because of the lack of real evidence for this population. So the main line of evidence for primary prevention comes from a very small subgroup analysis of the NSABP breast cancer prevention trial. And this study actually had included 12 women with the BRCA2 mutation and 8 women with the BRCA1 mutation. And when we look at the risk ratios for those who were in the tamoxifen versus placebo arms, there was the suggestion of reduced risk for women with the BRCA2 mutation, but not significant, and perhaps even an increased risk in women with the BRCA1 mutation. So from a patient perspective, it's not very convincing that tamoxifen may even prevent their disease. There is a lot more evidence on the role of tamoxifen when we look at the literature of contralateral breast cancer in this high-risk population. And quite a few groups, including ours, have looked at the impact of tamoxifen use following the diagnosis of a primary breast cancer in a mutation carrier and her subsequent risk of developing a second breast cancer. And this meta-analysis suggests about a 40% reduction in the risk of contralateral breast cancer. And this is really the evidence that most clinicians, I think, use when they're counseling women on using tamoxifen chemoprevention. So fortunately with our cohort, we decided to very recently try to conduct a prospective analysis to try to look at the impact of tamoxifen use and incident breast cancer in women with the BRCA1 or 2 mutation. So unfortunately, even in our almost 5,000 women who were eligible to participate in a purely prospective study, very few women in our cohort had actually used tamoxifen, and there were only about 202 women. So again, about 5% had used tamoxifen for chemoprevention. And here we see the distribution. Most had used tamoxifen, 35% had used raloxifene, and a very small number had used both tamoxifen and raloxifene. And so when we compared the number of incident breast cancers, there was no significant difference in this univariate table here, so 14% in women who did not use tamoxifen versus almost 11% in the tamoxifen users. So in our Cox proportional hazards model, where we adjusted for some important covariates, in particular oophorectomy, and took into account other factors such as age and country of residence. Here I'm just showing a snapshot of the results. So tamoxifen or raloxifene use for at least 2 years was suggestive of a potential protective effect, and the hazard ratios were approximately what we see in the general population, so perhaps a 40% reduction in risk. But we can see right away that none of these achieve statistical significance. So I think we haven't really answered the question. We can't confidently say that tamoxifen may prevent cancer, but I think we can confidently say that tamoxifen use is low, and I'm not sure, or we're not sure, if it's ever going to start increasing. So the next hormonal exposure I will be discussing is oral contraceptive use. And this is an important exposure when we're talking about young women who often initiate oral contraceptive use before they even know their genetic mutation status or have even considered preventative surgery yet. And there's been quite a few studies that have been conducted in this population, even some historic studies from our team. And what the data has consistently shown is that oral contraceptive use is likely increasing the risk of breast cancer, but is also conferring significant protective effect against ovarian cancer risk. And this is similar to what we see in the general population when we're talking about oral contraceptive use. And as I was putting these slides together, a really great meta-analysis was very recently published. And this here is showing a very comprehensive overview of the literature on oral contraceptive use and BRCA breast cancer. And when we look at the prospective data here on the top, it seems as though oral contraceptive use continues to be a risk factor for BRCA-associated breast cancer. What's interesting was that the retrospective studies continuously show no impact. So I think we can really consider oral contraceptives as something that might be increasing risk of breast cancer. But unfortunately, when you look at the literature as a whole, there's still a lot of unknowns. The studies haven't been sufficiently powered to consider dose-response relationships, timing of use, formulations, and whether the effect or impact on breast cancer risk is sustained or transient. So we know in the general population, the impact of oral contraceptives is a transient effect that tends to go away after a woman stops using the contraceptives. And so we fortunately have forged a collaboration with the Australian group and others, and we're really trying to conduct a more comprehensive look at this to come up with some more definitive answers. This meta-analysis also summarized the literature for oral contraceptive use on the risk of developing ovarian cancer. And again, the message is quite clear in that oral contraceptive use is associated with a significant reduction in BRCA-associated ovarian cancer. This appears to be a dose-response relationship and is stronger with more recent use. Some of the more recent studies haven't consistently shown whether this is an effect that persists or if it disappears after discontinuation of use. But this continues to be the strongest non-surgical protective factor for this population when we talk about ovarian cancer. So this is clearly a clinical conundrum, and it really just reiterates how complicated it is to manage young BRCA mutation carriers. You're not only considering high breast and ovarian cancer risk, you have to take into account personal history of disease, whether they are considering surgical prevention, and several other factors. So unfortunately, I think it's clear to the clinicians that it's not a clear-cut answer yet. And also in more recent years are more questions. What about these more contemporary hormones beyond oral contraceptives? There are a few studies that have been conducted in the general population where we're still seeing an increased risk of breast cancer with use of other types of contraceptives, such as IUDs. But there is really there is no literature in BRCA mutation carriers, except for one study that our graduate student recently published, and she took a look at the use of other contraceptive methods and the risk of ovarian cancer in this population, again, using data from our large cohort. This was a case control study, and if you look at the numbers here, it's fairly clear that most women had used oral contraceptives in our cohort, and this may be because some of these new methods, including the IUDs, are newer, and we had less women who had used implants or injections or IUDs. But what we did see was that some of these other non-oral contraceptives were still associated with a significant reduction in the risk of ovarian cancer, which is promising. So something that's even more complicated, I think, is the use of hormone replacement therapy and its role on the risk of breast cancer in this high-risk population. We know that from various trials, such as the Women's Health Initiatives and several prospective or observational studies, that combination hormone replacement therapy is associated with an increased risk of breast cancer. And so is this true also for women with the BRCA mutation who face significantly elevated risks of disease? So HRT, or hormone replacement therapy, has a very important role in managing these women, especially women who have not developed breast cancer yet, because we know and we are reassured that these women are removing their ovaries at an early age. But early surgical menopause is associated with several comorbidities, and HRT has an important role in managing some of these other non-cancer outcomes. So it's important to be able to counsel these women following surgical menopause or oophorectomy and be able to safely recommend HRT. So we conducted a prospective study. This analysis was limited to BRCA1 mutation carriers. And so we included 872 women who were unaffected with cancer, who had both breasts intact, no history of cancer, and we followed them over time for approximately 8 years. There were 92 incident breast cancers in this cohort, and about 57% had not used HRT after oophorectomy, and 43% had initiated HRT after the oophorectomy. So this graph here plots breast cancer-free survival over approximate 10-year follow-up period. So when we compare any HRT use in the orange line and no HRT use in the blue line, we see that the incidence was about the same, 13% versus 15%. But when we stratified by formulation type, we see that the incidence was significantly lower in the estrogen alone arm, so 10%, and 22% in the combination estrogen-progestin users. And this was a significant difference in these curves. Furthermore, the effect was even more striking. We see an even bigger difference in the risk profiles, with again combination HRT being associated with a higher 10-year cumulative incidence. Sorry about that. Compared to the estrogen alone. And so these findings are in line with what we see in the general population, that combination HRT is likely a risk factor for women with the BRCA mutation. And along with this clinical evidence, I think what this data is showing us is really complementary to a lot of the mechanistic and preclinical or experimental studies that are showing that BRCA mutation carriers may have this aberrant progesterone signaling that is predisposing them to cancer. And it might be the progesterone rather than the estrogen alone that is playing a more important role in these women. And yesterday, Dr. Koka talked a little bit about this, and this is a lot of her work also, as well as others. And it's been over a decade now that there's been a lot of preclinical studies showing that this progesterone rank signaling pathway is really important for normal mammary gland development, but also plays an important role in breast cancer development. And it appears to be really important in the BRCA1 models. And for any of you who may recall, about 5 years ago, there were 2 independent teams that showed in eloquent mouse models and experimental models that if we inhibited this rank pathway, we could prevent BRCA1 mammary tumorigenesis in the rat model. And using different techniques, whether it was genetic inactivation or pharmacologic inhibition of this pathway prevented BRCA tumors in the mouse model. And so this comes from one of these papers. It's a really complex overview of what's happening at the basic level, but a lot of the scientific evidence has showed us that in mutation carriers, it's likely this expanded luminal progenitor population that's hormone receptor negative, but rank positive, that's likely where the cell of origin for most of these basal tumors that we see, in particular in women with the BRCA1 mutation. And what these studies have shown us, and I think our observational study complements, is that if we could potentially inhibit this pathway, we could possibly identify a new chemoprevention option for these women. And so there has been a lot of interest in repurposing drugs such as rank ligand inhibitors, and in particular the use of denosumab, a drug that's been around for a while. It's used for the treatment of osteoporosis. And so there is one clinical trial underway and a lot of interest in the use of this drug to prevent BRCA1 associated cancer and provide a more evidence-based approach for chemoprevention in these women. So I've talked a lot about preventing disease, and I think that is one of our goals. And for several years, a lot of our work was looking at risk factors and things that are increasing or decreasing risk of disease. But a lot of our focus in our group, now that our cohort has matured, is what else is impacting not only risk, but, sorry, this is having a mind of its own right now. Oh. There we go. Okay, sorry. So we're not only interested in looking at risk and protective factors, we want to know how can we improve all-cause outcomes. We need to start thinking about mortality and death and what's predicting long-term survival in these women. And the first thing that comes to mind, sorry, I'm clearly having technical difficulties here. Okay. Yes, sorry, I keep scrolling. Sorry, I apologize. I'm used to keyboards. Okay, so one main exposure that I'm going to talk about is oophorectomy. So surgical removal of the ovaries and fallopian tubes and its role in influencing all-cause mortality in this population. So as I already mentioned earlier on, We know that this is the best way to prevent ovarian and fallopian tube cancer in these women, but it also is an important part of the treatment of breast cancer. Studies from our team and others has shown an important impact of oophorectomy following a diagnosis of BRCA breast cancer on death. But we can't ignore the non-cancer outcomes associated with early surgical menopause. And there is a large body of evidence in non-carriers from the Nurses' Health Study and the Mayo Aging Clinic and others that have shown significant adverse effect of early surgical menopause on non-cancer outcomes, including overall quality of life, cardiovascular disease, and cognitive decline. So although we want to prevent cancer, we really want to ensure we're not causing more harm in these women. And this is a question that comes up a lot from the patients themselves. And so, although there have been a few studies from us and others on this topic, many had methodologic considerations that we wanted to address in this more up-to-date analysis, including a small sample size, a short follow-up period, especially when you're thinking about death as an endpoint, and several biases that I'm not going to start getting into biostatistics, but two biases in particular is the inclusion of affected and affected women in your study, so not conducting a purely prospective look at this impact of the surgery, and also not considering oophorectomy as an exposure that can change, so a time-dependent exposure. And also, we know now that it's important to divide BRCA1 and BRCA2 mutation carriers. They develop different sorts of tumors, and the etiologies appear to be different. So now I'm going to present some very recent findings from our team. This paper is still not published, and we decided to focus on BRCA1 mutation carriers and look at the impact of bilateral oophorectomy on all-cause death. So we conducted a purely prospective study. So we excluded any woman who had any diagnosis of cancer at the time of enrollment and followed them over time. And there were 3,177 women who were eligible for this prospective analysis. 2,108 had undergone a oophorectomy at some point over the follow-up. 1,071 had not. And here I'm summarizing the causes of death in the entire cohort. We had 197 deaths so far. And right away we see that the proportion who died was much higher in the women who did not have an oophorectomy versus those who did. And so it's not surprising that the most common causes of death were ovarian cancer and breast cancer. And although our cohort is still aging, and I think over time we'll see some differences emerging, we can see right away that we didn't see any big differences in some of the other outcomes that we might be worried about, like cardiovascular disease and other outcomes. And so when we plot the cumulative mortality starting at age 35 to age 75, we see striking differences in all-cause mortality. In women who did not have a oophorectomy, it was about 65%, and those who had a oophorectomy was about 27%. And in our multivariate modeling, where we looked at oophorectomy and age at oophorectomy and whether they had had a oophorectomy prior to enrollment or after, it didn't really matter and we saw a similar reduction in the risk of death between 70 and 80% reduction in death. So overall, there was a 72% reduction in death when we conducted our multivariate analyses. So again, reiterating the important role of bilateral salpingo oophorectomy in this population. And again, we don't want to ignore the non-cancer outcomes in these women. It's very important. They face several quality of life issues, especially if they've had a prior diagnosis of cancer and they are not candidates for HRT. And at our hospital in Toronto, Women's College Hospital, we have a specialized clinic where the women are seen, the familial ovarian cancer clinic, where the women are followed closely to ensure that their symptoms are managed appropriately and they're receiving care to manage other comorbidities such as decline in bone mineral density, cardiovascular disease, and other factors. So I don't know if I even answered many questions because I think there's a lot of unanswered questions that we need to think about. Some of the studies I showed were only focusing on BRCA1 mutation carriers. In our cohort in particular, this is often due to sample size. We have a larger proportion of women with the BRCA1 mutation. So some of these have to still be addressed in women with the BRCA2 mutation. I think from a chemoprevention lens, we need to really think about rank ligand or progesterone or rank inhibition to prevent breast cancer as a really evidence-based approach to prevent disease in these women. And something that's emerging and becoming very important is whether we should be advising women to have their uterus removed at the time of oophorectomy. If the combination HRT is truly a risk factor for their breast cancer, perhaps being able to offer them estrogen alone HRT may be beneficial. And so we really need to think about whether hysterectomy should also be recommended. And although not very clear, there's some evidence to suggest that these women may be at higher risk of uterine endometrial cancers. Role of tubes-only surgery. I'm sure some of you that are gynecologists are hearing a lot about salpingectomy as a two-step process. I think there's a lot to be learned still about whether there's a role of salpingectomy alone. And again, how to safely manage menopause, which I think is an ongoing, something that's ongoing and cannot be a one-size-fits-all approach for these women. And finally, the role of screening, which we've heard about, and hopefully some more emerging markers that we could potentially use for monitoring ovarian cancer, and perhaps even finding a marker that could help in delaying the age at oophorectomy, because we're still left with age 35, which is a very young age for a woman to make such a drastic decision. So that takes me to the end. Lifetime risks of both breast and ovarian cancer are really high in this population. Managing these women is a balancing act, and it's very challenging depending on the woman's situation, timing in life. I don't think we can ignore the profound impact of oophorectomy on death. And it's really great that we're seeing that these women are listening to their clinicians and are undergoing preventative surgery. But we still have to mitigate these adverse non-cancer outcomes. So this takes me to the end, and I want to thank my team, Dr. Narrow and Dr. Metcalf, who are here. We're a really large team of trainees and research staff in Toronto, a little picture of us in our lobby. And of course, our contributors from across the globe, they play a very important role, especially the women who complete these extensive questionnaires every 2 years. And of course, our funding agency. So thank you, and I'm happy to take questions.
Thank you, Dr. Kotsopoulos. That was a lot of really good information, so we can start right here.
Thank you very much for such an informative presentation. This is Nick Touroutoglu from Greece, medical oncologist. I wanted to ask you if you have any experience with BRCA positive women who are seeking IVF support for family.
So we have specialized clinics in Ontario and Canada where we're from, and there's specialized clinicians who do deal with the pre-implantation genetic testing and freezing of embryos. And so I am not an expert in the field, but we do refer the women at our clinic to go seek some more information. And we actually have a great seminar series that I will plug, and we've had some of the fertility experts speak, and these are available online that I'm happy to share at a later time, where your patients can listen from the experts on what's options for them.
Certainly. I was just concerned about the large amount of hormones that are administered.
The impact of the actual treatment.
Yes.
So we have done one analysis. Unfortunately, it's fairly dated now. It's been a while since we revisited our initial paper, which I think is at least 10 years old. We found no impact of IVF treatment on risk.
Okay.
But the literature to date, I would say that's the most up-to-date literature, showing no adverse relationship.
Thank you.
And I would just add that I think that the relative risk one sees in the general population is also reflected in the BRCA carrier population. So for instance, that's seen in the oral contraceptive data that you showed. Relative risks are very similar. Only caveat, though, is that a relative risk of 1.3 in a standard risk woman is a much higher absolute risk in a carrier. So if you were planning to relook at your data, that would be really interesting.
Thank you.
Right microphone.
Thank you very much, Matteo Lambertini from the University of Genova. Great lecture. I have a question on hormone replacement therapy. If you have any insights on the impact of age at the time of initiation of hormone replacement therapy and duration of the hormone replacement therapy on the risk of developing breast cancer. And the second question, you have shown a question mark on the hysterectomy. In your practice, do you counsel women to have hysterectomy for using estrogen receptor only hormone replacement therapy? Thank you.
So thank you and nice to meet you, finally. So for your first question, in our paper, we did look at timing of use, duration of use. I don't remember the risk estimates offhand, but we did see a stronger effect in those who initiated younger than age 45. And it was dose responsive, and that I believe there was an 8% increase in risk with every year of use for estrogen plus progesterone. And what was interesting was that estrogen alone was actually protective. It had the opposite effect. And I can give you more details from the paper itself. For the hysterectomy alone question, I am not a clinician, but based on my work closely with the gynecologists, I don't believe they are currently counseling based on that. I think sometimes it is provider specific. Of course, our guidelines do not recommend for or against, but we are really trying to understand whether or not this should be an important consideration given these impacts of the HRT.
Thank you.
Yes, Center.
Thaddeus Beck, the University of Arkansas. This is for the panel as a whole. I have a lot of patients taking chemoprophylaxis, and they look at their Tyrer-Cuzick number, and they say, you tell me my risk is reduced by 50 or 75%. Why do I need to continue to get MRI screening? And I'm wondering if MRI screening in that risk-reduced population is still cost-effective. Thank you.
Dr. Lindros, do you have any opinion on that? In women who are taking medication to reduce their risk and the risk has been reduced by 50%, is it reasonable for them to back off on their surveillance strategies?
I do think also women who are not proven carriers, but have a 50% risk of being a BRCA carrier, they are advised to have the screening. So I think certainly also when you reduce your risk, it's not zero. And I would advise to continue with the MRI screening, certainly in BRCA carriers, yeah.
Yeah, so I get that question too, and I'm reluctant to endorse the idea that we can, in a particular individual, in the woman I'm talking to, tell her that her risk has been cut by the medication because, you know, these are population numbers, and so I think it's probably wiser to continue with the surveillance strategy. Center microphone.
Is it cost effective though?
Oh, that I don't think anyone has looked at. I mean,
moderate risk patients they've done their duty, if you will, and taken their medicine.
Yeah, good question, but I don't think we have data to address it. Yes, please. Is that Dr. DeCenzi?
Yeah, DeCenzi, Genoa, Italy. Great talk.
Thank you.
It seems to me from your data that there is a strong rationale for a trial of tamoxifen in BRCA carriers. You show your observational study with a 40% reduction, which is not significant only for a power problem, and also the meta-analysis on contralateral breast cancer do suggest a strong efficacy. So what you maybe need to select the right dose of tamoxifen. If you come tomorrow to the general session, you will see 10-year data of baby tam, but what is, in your opinion, the biggest hurdle to do a trial instead of, giving prophylactic mastectomy to these poor women?
Apart from funding, I don't know if the women will use tamoxifen. It's around, it's available. I just don't, in our clinic, in our practice, in our numbers, the number of women in our cohort of 18,000 women has been below 5%.
Well, I think Dr. DiCenzi is suggesting that you try offering them 5 milligrams.
Oh, like a different, oh. Okay, well, we can talk about that.
But there is a question online about your data on SERMs, which is that you did not mention a stratification by BRCA1 or BRCA2. You presented it for the whole group.
Yeah, so I didn't present everything, and this is still a work in progress. The paper, it's very preliminary data still, but there is too few. We did stratify. We see the same actually level of risk reduction, but the numbers become the confidence intervals become wider. It's based on 202 exposed women. So it's very limited.
Right microphone.
Thank you for that talk. My question is actually piggybacking off of this question about using tamoxifen. Looking at the newest data, targeted agents, BRCA, Olympia, what are your thoughts about exploring PARP inhibitors and moving it into the preventative space? Thank you.
I haven't thought about it a lot. I think it's come up in our lab team meetings. I think the biggest issue there would be toxicity and significant adverse effects with respect to a chemopreventive agent. I think the idea of it's possible from a scientific standpoint, but I think the toxicity profile would be the issue.
So I will take the moderator's prerogative and ask Dr. Brandy Heckman-Stoddard to add her thoughts to that question.
Thanks, Seema. Brandy Heckman-Stoddard from the Division of Cancer Prevention at the NCI. This is something we've been discussing a lot with AstraZeneca in terms of moving these into the preventive space. I think the idea of PARP inhibitors in BRCA carriers is about how you give them. I don't think anybody would give them the way they're given in treatment in the prevention space, but if you could give a short course once a year to clear those cells that have undergone the loss of heterozygosity, theoretically, it's a potential option.
Did you have a question too? Do you want to ask that?
I did. I want to piggyback on the question that came from the online person, and I really want to encourage you to stratify that data in the paper when it's published, because the data in the literature right now from P1 is based on 11 BRCA carriers, right? So any additional stratified data, I think, is really important.
Yes, thank you. I agree. And we have. I just didn't present it, but thank you.
Wonderful.
We will.
So, is that Dr. Weitzel?
Yes,
Yeah,
thank
it's
you.
Dr. Weitzel and then Dr. Dooley, and I think we'll be out of time.
In the same frame, thinking about stratification, talking about HRT for women who are BRCA, they're still at risk for sporadic disease. So do you have any receptor data on the tumors that occurred in those getting combined therapy, for example, are they ER positive in a BRCA1 carrier? Because my guess is that it's really that impact of the sporadic component of their risk as compared to the inherited.
Thank you. Wonderful question. And something we really are trying to address more is the pathology of our tumors. And we're really working hard to collect this information on our incident cancers. I think we had information on about half of the incident cancers in that paper. And I honestly don't remember what we saw. So I'm going to be honest. And I don't remember if we included it in the final analysis, but it's an important point. And along with looking at that, something I didn't talk about, what Dr. Khan had brought up, is even some of the other hormonal factors like the oophorectomy and whether we're preventing ER positive or ER negative, the type of tumors. And so this is something that our team is working really hard on trying to get the hormone receptors status of our cancers. So thank you.
So, Dr. Dooley, you have the last word. I think we're out of time then.
Well,
I have a follow-up on the salpingectomy thing. There is a current NRG oncology, bilateral salpingectomy versus bilateral salpingectomy oophorectomy trial, non-randomized, to enroll more than 2,200 patients and to be ongoing for the next 15 years.
Mm-hmm.
I'm at an institution that enrolls lots of patients in that trial. I am seeing weekly patients who are tested BRCA1, never counseled about their modulation of their breast cancer risk, had their tubes out, and then they show up in my clinic. And what am I supposed to do about counseling them, dealing with the risk, and the question of oophorectomy, because obviously reduces the risk for breast cancer. Their primary outcome is decreasing serous ovarian cancer. Their secondary outcomes are all quality of life measures and menopausal symptom stuff. No mention whatsoever about breast cancer risk. So what do we do with that population? And then having had some get oophorectomy, they get put on estrogen to control symptoms. And in their next set of screening, whether it's mammogram or MRI, we have increasing breast density, we have non-mass-like enhancement in the breast on MR, we have a whole series of issues. How do we, as clinicians, come home today with some way of dealing with this and also get our voices heard? No cooperative group trial with BRCA1 should never have gone forward without some of us at the table.
So, Dr. Kotsopoulos, I don't think we don't have time to get into all of the data, but do you want to make a comment about the new analyses that have questioned the value of oophorectomy for reducing risk in BRCA1 carriers?
Right. So I talked about bias in the literature, and some of the older studies, including ours, were biased in that they were including women who had cancer before they enrolled in the study, so they weren't aware of their genetic mutation status before they had cancer, and so they were having their oophorectomies after. And so a lot of the analysis had been biased for several statistical reasons. I won't get into all the nitty-gritty. But our more recent up-to-date analysis is not showing an impact of oophorectomy on the risk of developing breast cancer. That being said, BRCA1. Now, that being said, we know from Dr. Kelly Metcalf and Dr. Nerod's work that it plays an important role in following the treatment for breast cancer. And of course, the primary reason to remove the ovaries is to prevent ovarian and fallopian tube cancer. And as I showed, increase all-cause, ensure all-cause survival, so decrease all-cause mortality. The salpingectomy, I mean, it's being done within a clinical trial setting, so it's the idea of the NRG trial is the idea of having a two-step approach to preventing ovarian cancer. And so these women are expected to go back, from my understanding, to get their ovaries removed. And we're recently trying to evaluate if women are actually going back in time in our clinic to have their ovaries removed.
Right, so on that note, I need to thank you all for a really wonderful session and thank the audience for staying, and we need to do it again.